Just a brief introduction. Craniosynostosis occurs either as isolated brain deficit or within a genetic syndrome with additional anomalies of the limbs, on the heart, and the central nervous system. There are over 180 different syndromes. We know most probably the most common of them, such as Crozon, Appert, Cerebral, and Munch syndrome, but there are several other much rarer diseases. And imaging has a role in diagnosis because of the recognition of early closure of the sutures and in planning appropriate surgery. But in this context, most often the ancillary findings have been overlooked. So I will talk about brain malformation, vascular anomalies, and cranial nerve involvement, and just start with the brain malformation very shortly, just because you have already seen this very nice presentation by Dr. Titz. First of all, we have to divide these patients among isolated craniosynostosis with multisutural involvement, from the secondary craniosynostosis, from the syndromic craniosynostosis. And the first group is very easy to investigate because we have got a lot of literature showing that these patients usually do not present a lot of malformation. Actually, only 15% in this case series had brain malformation, and most of them had carry-on malformation. And you see the other malformations here in the table. And there was no clinical aspect or specific craniosynostotic form that was associated with this malformation. So we can conclude that the prevalence of this malformation is uncommon, is rare, and these abnormal MRI findings did not require further surgery that involved bone remodeling, and therefore pre-surgery brain MRI is not recommended in this subgroup of patients. A bit more difficult is when we have a multisutural craniosynostosis because, first of all, the data are scarce, and mostly studies are aggregated with other syndromes. And what we can get from this literature is that carry-on malformation is relatively common, about 1/3 of cases, with peak in some forms such as Mercedes craniosynostosis or oxycephaly. So probably we need some investigation when we deal with some specific subsets of patients. Secondary craniosynostosis. I was involved in several studies about mucopolysaccharidosis. These are some examples of MPS type 2, Hunter disease, and you see that there are different forms of craniosynostosis in the same disease. So about 20% of patients showed craniosynostosis, but the forms were very heterogeneous and did not correlate with the neurological phenotype, so they were present both in the severe and intermediate forms as well. So similar findings are present also in type 1 and type 4 and type 6. There are very scarce literature, but I've got a little experience on that. In the associated brain, skull, and spine abnormalities are often independent from the presence of craniosynostosis. This is another example of Harvard disease. You see the presence of craniolacunia and hydrocephalus and so on, a very severe involvement in this patient. What about syndromic craniosynostosis? There is a growing literature on that, on specific syndromes and also in aggregate sample of patients. Just to make a couple of examples, Hunter syndrome, which is a dominant disease with variable cognitive impairment. And I present very briefly two studies which are very important. The first one based on CT that investigated 94 patients, showing that ventriculomegaly is very common. About half of patients had this feature, and also the presence of crowding foramen magnum, about 1/3 of patients, and midline abnormalities in about 10% of patients. In addition, there were also encephalocele and hemiatrophies in some patients. Okay, the other study was based on the MRI, and it was able to show much more abnormalities because of the increased sensitivity of this tool. In particular, it was a study on 37 patients, and about half of them showed ventriculomegaly, and more than half of patients showed midline deficits and abnormalities. And moreover, some of them showed also hippocampal abnormalities, amygdala tumors, and so on. So MRI is very appreciated when dealing with syndromic forms. What is important is that MRI may also be helpful while following up the consequences of obstruction, in particular the progression of hydrocephalus. Very short, Munch syndromes, which is a very heterogeneous disease, dominant one, autosomal dominant, but some patients might present isolated hydrocephalus without craniosynostosis or hippocampal formation. I would like just to present this family with a child presenting with epilepsy and showing malrotation of the hippocampal formation. There is a normal example on the right side. And you see that the same malformation was present also in the father and the grandmother, but they were asymptomatic. So brain changes seems to be extremely heterogeneous within the same syndrome. Most rare syndromes have been poorly characterized, and the relationship between the clinics and the malformation needs to be determined. And recently there have been several papers on quantitative MRI analysis with the cortical thickness, perfusion, diffusion, tensor images analysis that have been performed in Rotterdam that are very interesting for understanding the pathogenesis of disease. Vascular anomalies, we have already heard about the internal jugular vein stenosis, which might cause communicating hydrocephalus, but there are also sometimes arterial abnormalities. There is this report about moya-moya, bilateral moya-moya in a patient with APERT, and there is also a study on the reduced intercarotid artery distance in this part of the brain, this patient father, showing that the distance between the internal carotid arteries might be extremely reduced, and this might have some consequences in the surgery of the basal of the skull. Cranial nerve involvement. I searched all the literature about the presence of cranial nerve involvement, starting with the olfactory nerve. Rhinencephalon abnormalities have been described in several craniosynostosis, and the first description was made by Maxim and Rosman, showing or reporting that crista galli was rudimentary and the cribriform plate was imperforate, and the olfactory bulbs and tracts were absent. Then there was another report by Submarian in 2019 showing the absence of the olfactory bulbs at the base of the brain. I looked at the MRI in my center, and I found out a couple of patients showing bilateral aplasia, such as in this trigonocephaly, and unilateral hypoplasia on the olfactory bulb. So this problem might be more common than we think in this patient. About the second, third, and fourth, and sixth cranial nerve, I treated them all together because they are involved in visual function, and we know that in craniosynostosis there are very often visual complications such as optic neuropathy due to increased intracranial pressure, strabismus, and other problems that might result in amblyopia. So these diseases are more common in the severe syndromic craniosynostosis, probably because of the cumulative effect of these anomalies. Just an example, among 141 patients, 2/3 of them had vision impairment in at least one eye, and 40% of them in both eyes. So optic neuropathy usually results from the papilla edema optic atrophy sequence, secondary to increased intracranial pressure. And optic nerve atrophy has a prevalence which differs widely among syndromic forms. In this very nice study, the optic atrophy was very rare among such as Chopton and München syndromes, while it was common in Upper, Crouzon, and Pfeiffer syndromes. In the diagnosis usually occurs at the age of 10 years. There was an association only with cardiac malformation, while the other parameters were not associated with optic atrophy, and the early diagnosis is necessary to lower intracranial pressure in order to prevent damage of the vision. And we can monitor this patient with ultrasound, CT, or MRI. For example, with coronary images, we can see the diameter of the nerve and the presence of the subarachnoid spaces of the cerebrospinal fluid around the nerve. But last month there was this very nice paper on OCT, the optical coherence tomography, showing that with this tool and with the fundoscopy and skull growth arrest, we can improve our clinical decision making in craniosynostosis. And there are sometimes also optic nerve hypoplasia that has been reported in Appert and in Crouzon and Pfeiffer syndromes. What about strabismus? Strabismus is reported very often in these patients. Typically is more pronounced in that case. And it might be related to abnormal orbital shape, but also sometimes to derangements in position, insertion, and function and number of extraocular muscles. In this example, you can see, for example, the abnormal position of the recti muscle on the left side, and on the right side you can see the atrophy of the superior rectus in this patient. In this case, this orbital imaging might be very useful for the management and the planning of the surgery. We have, of course, difficulties in understanding which is the best timing for the surgery, and most of all, the complex anatomy of this patient makes curative outcome difficult to achieve. So it is sometimes difficult to get a very good result. In some cases, the strabismus might be due to cranial nerves as well. It might be a symptom due to increased intracranial pressure. In most cases, the sixth cranial nerve might be involved, but in very rare cases, it might also be due to nerve aplasia or hypoplasia, such as in this case, there is a missing sixth cranial nerve on the left side, which is your right side, of course. And so far, no study investigated systematically this issue, so we have a lot to do in this field. About the trigeminal nerve, there is some reports regarding the deficit after surgery or the presence of trigeminal neuralgia in these patients, but there are also cases of trigeminal nerve hypoplasia associated with the pons and vermis fusion anomalies, such as in the Gomez-Lopez-Hernandez syndrome. You can see the different size of the trigeminal nerve in this patient. While the facial and vestibulocochlear nerves are often not very well investigated, even if these patients often have a conductive, sensorineural, or mixed hearing loss. In this patient, there might be atresia auris, recurrent otitis media, ossicular chain deformities, or inner ear changes, especially in Pfeiffer, München, Upper syndromes. This is a very difficult table, but just to show that in the third column that this patient, these different symptoms might present conductive hearing loss in red, or a mixed hearing loss in green-red, or neurosensory hearing loss in green. So it is a very common defect. And We know that some forms might present dysplasia, vestibular dysplasia, but there are no data regarding the nerves. But I've seen a patient with a single nerve in the internal acoustic meatus. I have to show here the magnification is just this dot here. Sorry. And this is the normal appearance of the cranial nerves inside the internal meatus acousticus. Usually we have different branches altogether in the same part of the internal acoustic meatus. And finally, regarding the inferior cranial nerves, there are no imaging data so far regarding these nerves and regarding their hypoplasia. However, there are several reports regarding nerve dysfunction, generally reported in increased intracranial hypertension. And even though this does not seem to be associated with the cerebral tonsil herniation. So in conclusion, in the last decades we have an improved management and outcome in these patients that let us to focus on ancillary findings such as what I've shown in this review. These findings might help to further improve our comprehension about these rare diseases and to tailor the management on specific issues such as cognition, hearing and vision and so on. And the collection of a large sample of these patients is crucial for improving our knowledge and for defining appropriate imaging protocols. Thank you for your attention.